A 34-year-old male presents with deep, progressive hip pain. I am showing you the pelvic radiograph. Describe the findings.
All right, let's take a look. The pelvic radiograph demonstrates a large, expansile, mixed lytic and sclerotic destructive lesion involving the anterior hemipelvis. There is marked cortical destruction with a large associated soft tissue mass, and the lesion exhibits a wide zone of transition. The sclerotic areas show a combination of popcorn-like and ring-and-arc calcification, typical of mineralized chondroid matrix. Given the aggressive features, wide zone of transition, and chondroid mineralization in a young adult, this represents a primary bone malignancy, most likely a chondrosarcoma.
What is the differential diagnosis for an aggressive lytic and sclerotic pelvic bone lesion in a young adult? And how do we distinguish between them?
The primary differential diagnosis includes chondrosarcoma, primary bone lymphoma, and osteolytic or osteoblastic metastases. Primary bone lymphoma presents with a destructive permeative bone pattern and a large soft tissue mass, but it typically lacks the characteristic ring-and-arc chondroid matrix calcification. Metastases are rare in this age group and usually present as multiple lesions with a known primary malignancy. The presence of dense, snowflake-like and ring-and-arc calcifications is the key radiographic feature that confirms a cartilaginous tumor like chondrosarcoma.
I am showing you a radiograph of a femoral lesion. Describe the findings and explain how it relates to this pathology.
The radiograph of the distal femur demonstrates a large secondary chondrosarcoma that has arisen from a pre-existing exostosis at the medial femoral condyle. There is extensive, dense, flocculent calcification within a huge soft tissue component surrounding the exostosis. This illustrates a peripheral chondrosarcoma, which results from malignant transformation of a benign osteochondroma. Malignant transformation should always be suspected if a benign exostosis becomes painful or continues to grow after skeletal maturity.
Differentiate between central and peripheral chondrosarcomas and explain how to distinguish chondrosarcoma from benign enchondroma.
Central chondrosarcomas originate within the medullary canal and are typically located in the pelvis or femur. They exhibit endostele scalloping, cortical erosion, and a wide zone of transition. Benign enchondromas, conversely, show well-defined margins, lack cortical destruction, and do not cause periosteal reaction or soft tissue masses. Clinically, the presence of progressive pain is highly indicative of chondrosarcoma, whereas enchondromas are typically asymptomatic incidental findings. Peripheral chondrosarcomas arise from the cartilage cap of an osteochondroma, and a cap thickness exceeding 1.5 centimeters on MRI is highly suspicious for malignancy.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior pelvic films to evaluate the rate of bone destruction. I would suggest obtaining a dedicated contrast-enhanced MRI of the pelvis to delineate the soft tissue mass, assess pelvic neurovascular bundle involvement, and evaluate the extent of marrow infiltration. I would also recommend a chest CT scan to stage for pulmonary metastases. I would immediately communicate these findings of an aggressive primary bone tumor to the referring team and refer the patient to a specialized bone sarcoma center for staging and biopsy, emphasizing that biopsy must be performed by a specialist to prevent tumor tract seeding.